Let's now go on and think about secondary brain injury. Any injury which can develop after the time of the initial insult. So we're still talking about brain injury, but now we're talking about secondary brain injury. And the first thing I've done here is I've divided secondary brain injury into intracranial brain injury. This is as a result of pathology that occurs within the cranial cavity. And then the other division here is extracranial, secondary brain injury. And this is injury to the brain that occurs as a result of factors operating external to the cranial cavity. So first of all, let's think about the intracranial lesions that can lead to secondary brain injury. What is it that can go wrong within the vault of the skull after the initial head injury, which can lead to subsequent further brain damage, brain injury? Well, what I've done here is I've divided it into different categories. Now, within the brain, of course, there are blood vessels, and as a result of trauma, the blood vessels can rupture. And when a blood vessel ruptures, it's going to bleed, and that blood is going to collect around about the damaged blood vessel, and that blood is going to form what we call a hematoma, a collection of blood where there should not be a collection of blood. And there are various compartments within the cranial cavity. This is still intracranially, where hematomas can develop. So there are different forms of intracranial hematoma. And the first one here I've got, an intracranial hematoma, can be extradural. Sometimes these are called epidural hematomas. It means the same thing. Extradural hematoma, this is outside of the dura mater. So if you remember your anatomy, an extradural hematoma is going to take up space. The hematoma is going to form outside of the dura mater under the skull. So this is outside of the dura, but under the bone of the skull. And this type here is a subdural hematoma. And a subdural hematoma is going to collect, the blood is going to collect underneath the dura mater. Now, what layer of the meninges do we find immediately underneath the dura mater? You might have remembered that's the arachnoid mater. So a subdural hematoma, the blood will collect below the dura mater, but on top of the arachnoid mater, above the arachnoid mater. And I just want to illustrate these anatomically now on a diagram. So on this diagram, we can see the bone of the skull here, the rigid vault of the skull. And this dark line here, as you would expect, immediately underneath the skull is the dura mater. Then underneath that we have the arachnoid mater, and here you can see the area occupied by the cerebrospinal fluid in the subarachnoid space. Below this we have the pia mater, and there we have the outer cortex of the brain. And from this diagram we can see that the extradural hematoma, the blood is occupying the space extra outside of the dura mater. So there's the dura mater, here's the bone of the skull, and here's the hematoma forming extradurally, pushing the dura down and compressing the brain which is beneath. Here we see a subdural hematoma. So here's the dura mater here. Underneath the dura mater is the arachnoid mater, the cerebrospinal fluid in the subarachnoid space, the pia mater and the brain. And here the hematoma is forming underneath the dura mater. It is a subdural hematoma. And here actually we can see the hematoma is forming inside the brain. It's intracerebral. So here a hematoma is actually forming inside the brain. So these are the sites of hematoma that can arise after a head injury, causing further damage to the brain. They are intracranial causes of secondary brain injury. For example, on this brain we can clearly see the two cerebral hemispheres of the cerebrum, and it's quite nice. You can see the structures of the gyri with the sulci in between. And this hemisphere looks reasonably normal, but clearly on this one you can see there's a very large indented area where the brain has been pushed in. And what's happened here is this patient has actually died of a subdural hematoma. So the hematoma has been occupying this area here and has compressed the brain tissue underneath the area of the hematoma. And of course, as well as compressing and damaging this local area of brain tissue, giving this punched out appearance, we know that because the subdural hematoma was a space occupying lesion, that it would have raised intracranial pressure as well. Still thinking about the intracranial causes, let's now think about cerebral edema. In England we spell edema with an O, so if you're watching in the States it's just spelled with an E. But it doesn't matter how you spell it, what matters is that edema is a collection of fluid in the tissue spaces. And after head injury, cerebral edema will collect in the white matter. The white matter will become dense and soggy because of the water in the interstitial spaces. And this happens for two reasons. The first is called vasogenic. Vaso means blood vessel, genic means to begin. So vasogenic cerebral edema begins with the blood vessels. And let's think about that one first. Normally in the brain, the blood-brain barrier separates the blood and the tissue spaces. And the capillaries have very tight junctions between them. So the situation will be something like this. Here's the cells of the cerebral capillaries. And what we're noticing is that the gaps between them are described as being tight junctions. They are tight together. There are not the gaps that we would get in other tissues. The liver, for example, has huge gaps called fenestrations. But in the brain, they're tight, close together. So the blood cells normally would go through the capillaries, and the various brain cells and tissues would be surrounding this area, surrounding the capillaries. And the reason that these endothelial cells are so tightly packed together is because they form a physical barrier, and that protects the delicate brain cells from things like toxins or infections. There's a blood-brain barrier, a barrier between the blood and the brain. But the idea with vasogenic cerebral edema is that the trauma can disrupt the integrity of the capillaries. That will make the membrane more leaky, and that will allow tissue fluid out into the interstitial spaces. So that's one mechanism of cerebral edema, the vasogenic cerebral edema. Now the second type of cerebral edema after head injury is called cellular cerebral edema. And this has got a much more complicated mechanism, but the fluid comes from the cells. So normally you might remember when you have a cell, there's fluid inside the cell, in the cytoplasm. The fluid part of the cytoplasm, you might remember, is the cytosol. And a lot of body fluid is stored inside the cytosol. But when cells are injured, this can disrupt the physiological integrity of the cell membrane, and that means that it can no longer compartmentalise the cell as it used to. And there are changes to the way it can control electrolytes and changes to the way it can control fluids. And that means that fluid can get out from the cells into the tissue spaces, again causing cerebral edema. So cerebral edema is a complication, it's an intracranial one, and it will also raise intracranial pressure. Let's think about the management implications now of patients with cerebral edema. Now, you might remember that tissue fluid forms at the arterial end of capillaries under the influence of blood pressure, and it's reabsorbed at the venous end of the capillaries under the influence of osmotic pressure. So what it is important to do is to maintain the osmotic pressure of the plasma, so the plasma is sucking back in the tissue fluid from the interstitial spaces back into the blood at the venous end of the capillary. So we don't want to give these patients large volumes of hypotonic intravenous fluids. We want to give them enough intravenous fluids, but they should be isotonic, meaning the same osmolarity as the plasma, or even hypertonic, with a higher osmolarity than the plasma. Because if we maintain the osmotic pressure in the plasma is going to suck the tissue fluids back in from the tissue spaces back into the blood. So it's a question of giving the right sort of intravenous fluids. Now, in the past, it used to be thought that these patients should be kept dry and dehydrated. And the idea there was that because the patients were dehydrated, the concentration of the blood would increase, the blood would become more osmotic, and that would suck more tissue fluid back into the capillaries. And we did this for many years. But we now believe that this is probably not a good idea. In fact, it's almost certainly not a good idea, because it's going to lower blood volumes, and that will lower the volume of the blood available to perfuse the brain, to maintain cerebral perfusion pressure, which is of course vital. So patients with cerebral edema, give them the intravenous fluids that they need, but make these isotonic or hypertonic solutions. So we've seen that extradural hematomas take up space, they're space-occupying lesions, and can increase intracranial pressure. The same is true for subdural hematomas. The hematoma takes up space within the cranial cavity, therefore can contribute towards raised intracranial pressure. We've seen that the same is true with cerebral edema, because the water is taking up space. All these can lead to intracranial hypertension. In the cranial cavity, high pressure, raised intracranial pressure. Let's look at raised intracranial pressure now in some more detail.